This is an incredible honor for me to be awarded this prize. I know I follow in the footsteps of some real giants in global health, and I think what John didn't say is that in my field of global health, this is probably equivalent to the Nobel Prize. Actually, it's very rare for a Nobel Prize to be given to people who work at the nitty-gritty, messy end of healthcare delivery. And it's an enormous honor. I think the title of my talk really captures something else that I wanted to say before I launch into the lecture, which is that if there was one quintessentially global subject in the practice of medicine, it is mental health. And the reason is every country has not done well enough as it should. And so although a lot of my work really focuses on my work in India and sub-Saharan Africa, I am sure that you will see that I will start drawing connections with North America, in particular through my new home in Boston, that illustrates how much of the work that I do, in fact, has a bearing across the world, not just the work that I do, but that the global mental health community has done. Now, as you can imagine, being a global health researcher involves wandering the globe. And what I'd like to start with, and I should also say that my talk today really, through the instructions of the foundation, is really to illustrate primarily the work that I've done. And so I want to just make a disclaimer that the work that I've done isn't exclusively mine. It's always been done in partnership with many other people. And there's also a larger body of researchers who have collectively with me had an impact on some of the things that you will see in my presentation. So I started off, let me make sure there. Yeah, so this is, of course, a map of the globe. And I started off here in India. That was where I did my medical education in this building here, which was the very aptly named King Edward Memorial Hospital in the city of Mumbai, one of the best medical schools of the country. Soon after I finished my medical training, I got a Rhodes Scholarship that took me to Britain. And after completing a higher degree in medical research, at the time I was working on dementia in a highly sophisticated laboratory that was doing neuroimaging and trying to relate, in those days neuroimaging was very young as well, and we're talking of CT scans at that time, and trying to relate the neuroimaging findings with behavioral features so that we could better understand the neural correlates of human behavior. I then moved to London, where I trained in psychiatry at the Maudsley Hospital, and that's the image you see here. The Maudsley Hospital is considered widely as perhaps the most prestigious psychiatry residency training programs in the world. And so here I had trained in two outstanding medical schools, one in Bombay, well, three actually, Oxford, and then in London. And so I was properly trained to be a psychiatrist in a place exactly like one of these institutions. The wanderlust in my life, it was certainly not global health, then took me far across to the other end of the world, where I landed up working in a real-world, messy frontline clinic belonging to the University of Sydney, except that this was not at the Opera House end of the city of Sydney, but exactly at the opposite end. It was a town or a suburb of Sydney which was curiously called, and I was only later to discover why, it was called Blacktown. When I started working there, I suddenly discovered that, of course, the people in this neighborhood didn't look at all like the people who lived in and around the Opera House. They were all members of Australia's very neglected Aboriginal community, and that, of course, brought me back as to why this particular area was called what it was. But I also discovered here that much of what I had learned about the individual underpinnings of mental illness, from the biological and genetic explanations to the environmental exposures that were primarily about that person's life, those frameworks couldn't fully explain what I was seeing in these communities. And it was here, through the readings of incredible writers who had delved deep into our understanding about why Aboriginal people died about 20 to 30 years earlier than white Australians, that I began to understand that the way to really unpack the mental health problems faced by these communities was by thinking about ideas like historical trauma, which really sprang well outside our narrow individual biomedical understandings of mental ill health. The idea that experiences that preceded your own life could somehow affect your health and well-being was, for me at that time, an astounding idea, because nothing I had trained in medicine had actually prepared me for such an etiological hypothesis. Having now rediscovered or reimagined what etiology meant in mental health, I then found myself doing my doctoral studies through King's College London, but based for 2 years in the medical school at Harare in Zimbabwe. Again, brought there largely by wanderlust. But here I had to now reject yet another major assumption that had been firmly ingrained in my mind through my biomedical training, and that was that only doctors deliver healthcare. I found myself in a country where I was one amongst 10 psychiatrists to address the mental health needs of 10 million people. And to give you a sense of how different that was from everything else I had experienced before, there were more psychiatrists in the corridor of my research institution in London than there were in the whole of Zimbabwe. And of course, 9 of us were based in the city of Harare, which effectively left 1 psychiatrist for 9 million people. And so it was very clear with these numbers, with these stark numbers, that everything I had learned in the hallowed corridors of the Maudsley Hospital had to essentially be relearned. Or be unlearned first. And I had to reimagine how would I actually deliver mental health care in places where there were no mental health professionals. And of course, this is my journey, this is where my journey into global health began, because of course the same challenge was being faced at that time by people trying to save lives affected by HIV/AIDS. This was of course the mid-90s when HIV/AIDS was wreaking havoc across Southern Africa. And this was also the time when we had these in hindsight, morally unacceptable questions that were being raised about whether African health systems were ready to deliver antiretroviral drugs. This was, of course, the horrific period in which 10 million or more Africans died when they shouldn't have died because we already had scientific discoveries that would have meant they would be alive today. And of course, the conversations around then, I remember very well, were whether Africans could afford these medicines and whether their healthcare systems had sufficient sophistication to deliver these medications. And I saw around me the incredible hard work amidst such tragedy of people who then, of course, global health didn't exist then, and Peter Peart, of course, who got the award before me, would have told you that the history of global health as a discipline that really sought to marry medicine with notions of social justice was really born around the HIV/AIDS pandemic. And of course, I saw that play out all the time in the mid-90s. And so I began to get inspired by that movement, and that took me down the track of research that I'm about to talk to you about. I returned to India in the mid-90s, where I set up an organization called Sangat. This was done because I wanted to break away from the psychiatric research institutions that existed in the country, but instead embed a research institution that worked in communities along with primary healthcare centers and community structures. And no medical school was ready to do that at the time in the mid-1990s. And so I set up an organization with 6 other individuals. At the same time, I was offered a professorship at the London School of Hygiene and Tropical Medicine. And so then for about 20 years, a flourishing research program led by myself and then a number of my younger researchers occurred with a large amount of funding from the Wellcome Trust. And I'll be summarizing some of that research in the next few minutes. In 2000, it was around this time that I also had the great opportunity to start mentoring researchers in Africa. This is a picture of Eugene Kenyanda, who is now one of the leading researchers on HIV and mental health and leads a large program at the Makerere University in Uganda. I received a large grant to develop programs of work in 3 other African countries, Ethiopia, Uganda, and South Africa, plus Nepal and India, working now with governments to incorporate and integrate mental health care packages within their routine healthcare systems. And exactly 2.5 years ago, I accepted the position at Harvard Medical School in the Department of Global Health and Social Medicine. So it's been a long journey, and what I'm going to try and do is, in about half an hour, capture some of the key essence points from that career that demonstrate, first of all, not only how science can make a difference, but also, very importantly, the limits of science in actually creating differences on the ground. When I started 25 years ago, it was very clear to me that mental health was on nobody's priority list, not least of all those who worked amongst under-resourced populations in under-resourced countries. These are some of the kinds of arguments that I had to confront. The first one is actually an argument that I myself harbored, having had not just training in psychiatry, but also in medical anthropology. The idea that mental health problems as defined by psychiatry were cultural constructions made by Western psychiatrists who had largely based their research in white, urban, upper-class populations, and that they were largely commercially driven. This was a very strong, prevalent view at the time, and indeed continues to prevail even today in some sections of society. Another argument was that we were simply medicalizing suffering, and of course you hear a lot of those arguments around the Aboriginal experience. Of course, if historical trauma was very important, then how well do biomedical understandings really fit in terms of etiology and management? That this was not a priority for poor people or poor countries. Poor people, as it were, seem to have more important concerns in their minds, for example, food, but also if we considered health, physical health always was more important than mental health. And that finally, that we simply did not have adequate resources to address mental health problems in under-resourced countries because, of course, the prevailing model of mental health care was very expensive people sitting in expensive buildings and spending years with you with very uncertain results. This was a very dominant view in the global health community. It may have been completely false, but that was the view I had to address. And so for the first half of my research career, I had to begin addressing these assumptions, these ideas, some of which, as I said, were skeptical ideas that I also harbored myself. The first part of my work really investigated whether or not mental health problems were relevant in different cultural contexts. And I did this through a combination of both ethnographic and qualitative studies as well as epidemiological studies. This paper, for example, was a description of my understanding of concepts of mental illness held by traditional and faith healers in Zimbabwe. I have done a lot of work in listening directly to the first-hand lived experience of people affected by mental health problems. In these papers, I describe the experience of mothers affected by depression and the experiences of trauma-related mental health problems by people who were affected by the horrific pogroms against Muslims in the state of Gujarat in 2000 in India. I spent a number of years working with the Ministry of Health in Mozambique, then the poorest country in the world, just recovering from an extremely protracted civil war, to understand better how communities were recognizing and managing severe mental and neurological disorders. And yet another example of the work on cross-cultural relevance was to examine the experiences of living with someone with mental illness, in this case particularly looking at experiences of discrimination. The second kind of research inquiry was to try and connect mental health with established global health priorities. If I couldn't really prioritize mental health because in itself it was an important form of human suffering, then maybe by examining how it actually was correlated with other forms of global health suffering might help me make the case better. And so a parallel research inquiry looked at the relevance of mental health with a variety of global health priorities, such as infant undernutrition. This was with the first paper, the first study, to demonstrate a large association longitudinally between depression in a mother and infant stunting and undernutrition, a finding that now has been replicated in about 50 studies around the world, so that today it is widely acknowledged in the child nutrition community that maternal mental health is a critical modifiable risk factor. I have looked very much more at reproductive and sexual health in women, in this case in a study in Benin, looking at the impact of child loss and obstetric complications on women's mental health. Looking at the relationship of mental health in its broader sense, including interpersonal violence on women's sexual health. This was an important piece of work for me because at this time when women were coming to clinics around the developing world with complaints like vaginal discharge, they were automatically being assumed to be suffering from a reproductive or sexually transmitted infection, which of course, as you can imagine, has enormous implications for women's relationships with their husbands. And of course, there was almost no bacteriological evidence that this was the case, but nevertheless, they would get this diagnosis and get an antibiotic course, no matter what the consequences were for women's personal lives. We ran a very large program of work trying to unpack the infectious and non-infectious etiologies of these complaints and found there was absolutely no connection between infection status and these symptoms. And these symptoms were almost entirely somatic equivalents of very difficult personal lives and frank mental illness. My colleague Eugene Kinyander has built a very large program of work on HIV and mental health in Africa, demonstrating that you cannot have an HIV/AIDS program that does not address mental health at the same time. The relationships are so intimate that, in fact, to deal with HIV without addressing mental health is not to provide comprehensive care. More recently, I've turned my attention to chronic diseases, which have become the leading causes of death and disability around the world, including the developing world. In this paper, we were able to harness data from 60 countries demonstrating that when you suffered from cardiovascular disease or diabetes, if you also had comorbid depression, the levels of disability in healthcare use had quadrupled. There seemed to be an exponential increase in the social and functional outcomes when depression coexisted with these conditions. And the final example of my work on trying to connect mental health, global health, is to do with mortality. This is important because right up until today, it would be fair to say that the leading priorities in global health were the diseases that killed. And I think that's fairly justifiable, really, especially if that mortality was avoidable or preventable. And for a long time, it was felt that mental health problems couldn't be prioritized because they didn't kill. Yes, they made you sick, but they didn't kill you. So at least we had to put all our scarce dollars into diseases to save lives. So this work, we were able to show for the first time that actually that was not true, especially for young people, that in fact mental illness in the form of suicide was not just a leading cause of death, but the leading cause of death in young Indians. And of course now we know it's the leading cause of death in most young people, in most populations around the world amongst young people. The third kind of priority area for global health was about social determinants. And again, this went back to the assumption that, that mental health problems did not matter to poor people or to women living in disadvantaged circumstances. A whole body of my work has been epidemiological to look at the social determinants of poor mental health. We've examined the associations with poverty, with gender-based disadvantage and its effect on mental health of mothers, on violence, and most recently, we've also been looking at the impact of mental ill health on economic consequences. So it's not just about whether living in disadvantaged circumstances increases your risk to develop mental health problems, but is it the case that when you have a mental health problem, you are more likely to slide into poverty? With this work, we were able to demonstrate, comparing anemia, reproductive tract infections, and depression, that only depression was associated with catastrophic health expenditure and therefore actually was a route to further impoverishment for these women. So to summarize this body of work, we were able to show for over a 15-year body of work that these were real causes of suffering in diverse contexts, that there were profound impacts on health and social outcomes, and that there were vicious cycles of disadvantage that were set up. I presented this evidence, I remember very well, about 15 years ago at the World Bank. And I had a room like this full of economists who looked at the evidence. They were moved a little bit. But then, of course, they said, so what? The problem is that this is all fine, but there are so many forms of human suffering that we have to deal with in this world. We still can't really see the importance of mental health when compared with other forms of human suffering because you don't have any solutions for this form of suffering. Because, of course, the solution is too expensive, unaffordable, and of uncertain effectiveness. So began another journey in my work, and this was borrowing heavily from other global health disciplines to look at the use of available resources to deliver mental health interventions. Over the last 10 or 15 years, a lot of my work has focused on leveraging available human providers, particularly community health workers. We have taken on a kind of a program of work which takes evidence-based interventions, simplifies them in ways that they can actually be task shared with frontline providers, and then run randomized control trials to investigate their safety and their effectiveness. And so I can tell you very confidently today, yes, we can deliver a range of mental health care interventions. How diverse? For people with dementia, for people with schizophrenia, for children affected by autism, brief psychological treatments. In this particular case, this is the briefest psychological treatment, highly mechanistically informed, targeting the social withdrawal that is characteristic of people with depression. This was a trial in India for severe depression, but I'm really highlighting this because this brief treatment is now coming to Canada. Thanks to a PCORI grant to my mentee at the University of Toronto, this treatment is being adapted for use with mothers and will be rolled out over the next 4 years in a large trial in Toronto and also 2 sites in the US, which is a nice example, actually, of how an innovation from one of the poorest countries in the world can actually be re-engineered to be used in one of the richest countries of the world. We similarly have examples for drinking problems and for perinatal depression. In fact, this body of evidence, all of it derived from randomized controlled trials, is so huge that we now have several systematic reviews. Altogether, my rough calculation is we have more than 100 randomized controlled trials now investigating the use of non-specialized workers who may range from nurses and GPs at the one end to lay people in the community and peer support workers at the other to deliver mostly psychological and social interventions for a very wide range of mental health conditions, and to do so with great effectiveness. More recently, we've also turned our attention to prevention. In my own program of work in India, we are now working with both individual-level preventative interventions, such as the first paper here, which is describing a trial we just recently published on working with older people who had risk factors for depression, such as older people with chronic painful conditions. But the second example is something that excites me enormously, which is now working with environmental interventions in ecosystems in which you can modify the environment. A great example would be a workplace, but in this particular instance, we're working in schools and secondary schools. Exciting because the same intervention that really worked with students to change the social environment of the school was being done at the same time, unknown to me, in Britain. And I only discovered that when my mentee, my PhD student who led this work on the ground, was examined by the PI of the English trial. And the English and the Indian trials were published the same issue of The Lancet last October. Really completely opening up a new window of thinking about theory-driven interventions in totally different contexts, completely different educational systems, but with the same common theory and exactly the same results. This was a very important way of actually confirming, in many ways, the very central role of social environments in the etiological pathway for poor mental health for young people. We're at very early days on scaling up. Admittedly, this is a very important challenge for us, but nevertheless, we're learning. I've been involved in work in rural communities in India to increase demand for mental health care, which is very low in many parts of the world because the historic expectations of communities has been not to get good quality care, and therefore they don't demand it. And through the PRIME consortium that I mentioned earlier, we have been able to learn very important lessons, and they have not been easy lessons because many of them are lessons of failure, on how to integrate these mental health care programs within routine healthcare systems. And unfortunately, still a lot to learn on how we can address some of these barriers, and some of those lessons are informing the work that I am planning to do in Harvard. In many ways, friends, this body of science, and I again want to stress the point, is really, it goes well beyond just my work, has redefined in many ways the what, the where, the who, and the how of mental health care. It has led to the birth of global mental health as a very vibrant and exciting discipline of global health. I launched a master's program in global mental health in the London School of Hygiene and Tropical Medicine 8 years ago. Everyone asked me, you really think you'll have enough students to come and for a full-time residential master so specific? Well, last year, the master's program had more than 250 applicants for a ceiling of 50 seats. And in fact, this has been the case for the last 3 years. It's been oversubscribed. One of the things I've done with my science is to engage with a number of communities that are concerned with mental health to make sure that this science actually has an impact. With the Academy of Global Health, I worked very closely with the Lancet Medical Journal to disseminate this research. With the NIMH, I've worked as the co-chair of the Grand Challenges for Global Mental Health to develop a research agenda, which is now backed by more than $150 million of new funding. And as academic resources for students of global mental health, written a number of textbooks, including this particular one. Obviously, we also want to engage with policymakers and practitioners. With clinical practitioners, I've served on the World Health Organization's Guideline Development Group to develop clinical guidelines for frontline providers in primary and secondary care. I've set up the Mental Health Innovation Network, which I want to specifically mention here today because it was funded by Grand Challenges Canada, which is an online repository of more than 150 innovative ways in which people around the world, including in high-resource countries, are delivering interventions for prevention, promotion, and recovery. This was a manual that I wrote first in 2003 before we had any randomized controlled trial evidence on the use of community health workers. And the second edition really actually is greatly upgraded to incorporate all that evidence. As was mentioned by John, I was on the drafting committee of India's first national mental health policy, and at the global level, I've led the World Bank efforts to inform policymakers on scaling up packages for mental, neurological, and substance use disorders, and most recently, just last year, for the United Nations General Assembly on the committee that produced the Time to Deliver report to the heads of state at the UN on responding to the NCD and mental health crisis. But more important than any of these for me has been the work that I've done with civil society. As I mentioned to you earlier, the HIV/AIDS story has a very important part to it, which I hadn't emphasized. And that was that science alone was clearly insufficient in the mid-1990s to make these life-saving drugs available to poor people in poor countries. It was the moral argument. And the moral argument wasn't made by scientists alone. It was actually made by people living with HIV/AIDS. Scientists played a very important role in developing the evidence base, of course, without which we may not have had any advocacy, but it was insufficient. And inspired very much by the HIV consumer movement, I have worked very hard to support the development of a similar movement of people with a lived experience with mental illness. So we launched the movement in 2008. Over the last 10 years, last 6 years, it's been led by people with a lived experience of mental illness. And last year, the movement launched a specific parallel group to encourage the development of networks of people with serious mental illness around the world, the Global Mental Health Peer Network. And this is a real champion for me because the science I do, they adopt and they disseminate with the user community in a way that I could never reach out to because of matters of historical mistrust that really pervade the mental health sector. I'm also working a lot with young people. This is an example of an ongoing program that we have in India that is engaging young people in conversations about mental health. And a really key message about this conversation is let's talk about our mental health with the comfort, with the frankness that we talk about our physical health, because that is probably the single best way to, in fact, combat some of the challenge and stigma. It's this body of work that has led finally to the inclusion of mental health alongside all the other major development priorities in the United Nations Sustainable Development Goals. At this point, I could say that it's time for me to hang up my boots and find a nice beach somewhere and spend the rest of my life feeling quite happy. But it's actually also time for me to take a reality check. How much has all of this science actually made a difference on the ground? Unfortunately, what I'm about to show you is a rather very different picture about the lack of impact and the lack of response. Over the last 25 years, and this is work done by previous year's Gairdner Global Health, the Canada Gairdner Global Health Laureates, Chris Murray and Alan Lopez, their global burden of disease work, which shows that no matter how you classify countries according to their socioeconomic development status, over the last 25 years, the relative or proportionate burden of mental and substance use disorders to the overall burden of disease has gone up 50%, and it's going to keep going up. Why? Predominantly because we're doing a good job in controlling some of the other causes of burden of disease and doing a hopeless job in addressing mental health. In the meantime, suicides have now become the leading cause of death in young people in many countries, including in India, where I spent half the year. And substance use is the second most important leading cause of death in young people or in some of the other countries that I live in, including in the US. The coverage of minimally effective treatments for mood, anxiety, and substance use conditions in the latest surveys is incredibly low. More than 90% of people with these conditions do not receive minimally effective treatments. This is an astonishing failure of healthcare systems. But even in the richest countries of the world, the figure doesn't approach even 50%. And that tells us something quite important about the fact that it isn't just more money that needs to be spent, but also how we organize the architecture of mental health care. Tragically, images like this, which many of you in this country may not have seen for 100 years, these are actually images of mental hospitals taken in a variety of developing country settings in the last few years. This is still what happens under the name of mental health care in many institutions, and I'm sure you'll all agree this is a term I use of my mentor, Arthur Kleinman. It is really a gigantic failure of humanity that we should treat people in this way simply on account of the fact that they suffer from a mental illness. In rich countries, certainly like the US, I don't know much about Canada, we certainly don't have institutions like this. What we've done is we've replaced them with prisons. And so that now people with serious mental illness either sleep rough or they land up in awful shelters, or worse, in America, they land up in prison. So that if this statistic is true, it would mean that more people with serious mental illness today in the US are behind bars than they are in any form of a healing setting. To me, this is a human rights scandal that pervades every aspect of government, not least the ministries of finance and health. This chart shows you the proportionate burden of mental health problems in all countries divided according to their income status. It's about 25 to 30%. And this figure shows you the proportion of the health budget that is actually being spent on mental health. And what the single message on this slide is that no matter how rich or poor a country is, every country disproportionately underinvests in mental health care in reflecting the actual burden in those countries. And the richest countries in the world, when the richest country like Canada, for example, disburses development assistance to the poorest countries in the world to strengthen the healthcare systems, on this slide you can see almost all the money is going to 3 or 4 conditions. Mental health problems and non-communicable diseases get virtually nothing. So that what happens is you get a skewed healthcare system response in most countries. If you have HIV/AIDS, you get very good care. If you've got schizophrenia, you get no care at all. And this is a sort of absurdity in the way that we are actually dispersing resources that really demands an explanation. I want to end by thinking about this reality check and where I'm headed in my own work going forward. I'm not hanging up my boots. I still have a lot more work to do. A few years ago, under the great mentorship of Richard Horton, who's been a terrific editor-in-chief of The Lancet and an enormous champion of mental health, he asked me, Vikram, with this rather dismal story now, a dismal story emerging in all countries. I don't know if some of you are aware that suicide rates in the US in young people have doubled in the last 10 years. And I was just talking earlier with John. I said, imagine if we had a figure like that for any other health condition. Just think about it. In this phase of human history, that a cause of death doubles in just 10 years. You'd imagine that society would be up in arms and say, what in heaven's name is going on here? But, it's just one more mental health statistic that people will say, oh, that's bad news, and then forget about it. So how do we change the conversation around mental health? And this was what 28 of us got together, and we really interrogated, were we wrong in some of our tactics over the last 15 years? In order to reduce suffering due to mental health problems, our tactic had been largely to focus on the treatment gap. This is a very biomedical approach. We thought this was the right approach at the time when we championed it. Let us advocate for more people to be able to access biomedical treatments, evidence-based clinical interventions. And we've felt that this is no longer going to be a sufficient strategy, and that we need to start focusing on some other fundamental gaps if our message has to ring with a wider set of stakeholders. And these are the other gaps that we thought are very important. The first is the quality gap. It isn't just good enough to be able to get treatment, but to get the right interventions at the right stage of your mental health condition. It isn't the case that mental health conditions are simply binaries. You have it or you don't, but you often have degrees of severity, and for the most of us, those degrees of severity tend to be mild or moderate, and that those interventions that I showed you earlier, that is to say, psychosocial interventions delivered by non-specialized providers, must form the foundation of the healthcare system in a coordinated way with more specialized care. Reducing the prevention gap, we recognize that the areas of global health that have achieved great traction are those which have clear-cut targets for prevention. I remember when the first Lancet series on global mental health was published in 2007, we had Jeffrey Sachs giving the keynote talk, and I remember him telling me and all my colleagues, what you people need is you need the bed net for mental health. alluding to the fact that there was huge global interest in malaria because there was a relatively cheap technical fix for prevention. And I and my colleagues have followed that idea, but I think it was a wrong route to take. We have to embrace the complexity of understanding that environments are just as important as vectors in understanding human disease. But that addressing environments is a more complex and messy business than addressing mosquitoes. And if we continue to think that the only drivers of global health will be finding simple fixes like vaccines and bed nets, then we will really never be able to address the challenge of mental health problems. And we do have targets. Those targets lie in early life environments, at home, in preschool years, in schools, and now potentially the digital environment. But we need to grapple and embrace the idea of environmental interventions if we're ever going to be able to prevent what is already happening, I think is a really very, very concerning epidemic of mental health problems in young people. And the credibility gap, of course, is about the biomedical approach being championed without full engagement of the community, particularly people with a lived experience. To finish off then, I intend in the next phase of my career, which might be the final phase of my career, to really go beyond just science, but to really develop a set of tools and products which can be used by governments, can be used by civil society to achieve some of these goals. So we're building a digital platform for training community health workers to deliver evidence-based psychological treatments so that we build the foundation of the healthcare system. We are developing a leadership program for people at the top of the healthcare system to understand better how some of these ideas and aspirations can be made into reality. We're developing metrics using the famous countdown model in global health that can be used by countries and provinces to evaluate their mental health care systems and the impact of investments. We're developing a program in which we're stitching together early life environmental interventions to be delivered at a population level so that we can demonstrate their impact on reducing the incidence of mental health problems. And finally, a program of engaging people with the lived experience of mental illness so that they can be right at the center of designing, planning, and evaluating mental health care programs. In the end, friends, the moral imperative for mental health in the era of sustainable development, many of you may know the slogan of the SDGs is leave no one behind. I'm afraid we are leaving people with mental health problems behind all the time. That people have the right to be protected. By this I mean, for example, if you have suffered traumatic, either historical or recent trauma, you have the right for your government to put into place systems to help protect your mental health from harm. And when you have a mental health problem, you have the right to quality care of your choice in the same way that people with cancer or heart disease have care of their choice, and not care that is thrust onto you against your will, and a right to life with dignity and respect, which still is denied to many people with mental health problems. We just have to walk around the streets of big cities in North America, and you can see evidence of that very easily. I want to end in my last slide to just acknowledge the funders who've actually made my program of work possible, without which I certainly would not be standing here before you as a recipient of this pride. Most importantly, the Wellcome Trust, which in 1995 took a very risky decision to support me. I say very risky because it was very, very unlikely that any funder would support anyone who wanted to go to India to start a mental health research program back in 1995. Now that I sit on the Wellcome Trust panel, which is a wonderful privilege for me to now be on the other side of the interview table, I've realized that taking risks is what we should be doing in our research funding role, especially with younger researchers, because those are the ones who will take the most risks. And being able to absorb that maybe, as with all risk-taking, some of our bets will not work out, but the few bets that will may yield enormous results. By the time you're 50, I'm sorry, the horse has bolted. You get boring incremental research. It's the 25-year-olds who come with outrageous sounding ideas are the ones that we should really be supporting. And I love the Wellcome Trust because there's a part of our discussion which always is, isn't that a crazy idea? And somebody says on the panel, yeah, but it's plausible. And that person is the right person to pull it off. And I love that conversation because risk-taking, I believe, is all too rare in many of our funding decisions. And I'm very, very indebted to the Wellcome Trust for having taken this huge bet and gamble on me right at the beginning of my career. The MacArthur Foundation was another funder who took a huge bet on me by actually supporting my work with adolescents in schools starting in 1998. and has continued to support me and the organization I started in India ever since then. And then, of course, a number of other funders who have followed as my research career began to flourish. It was much easier, as often happens, to start getting support from others. But it is important to acknowledge those who were there at the very start of my journey. So thank you all very much for your patience, and I think we probably have 10 minutes for questions.
Dr. Patel, thank you very much for a very inspiring presentation. I can tell you, as a senior administrator of a university, a very complex environment with over 5,000 employees and over 40,000 students coming from 140 countries, mental health is a real thing. And I can tell you that we're committed in providing services and delivery of care for these very complex ecosystems. So thank you very much for your presentation. Do we have any questions from the audience? And if you do, can I ask you to go to these microphones, please, so that your question can be heard by the participants? Please.
I am Smita Pakhale. I'm a respirologist, and I do work with the marginalized population, such as homeless and substance use. And we are developing some models of integrating and how to disseminate on the ground. But my question is, you mentioned about the indigenous population and your eyes opening to the intergenerational trauma. And the issues faced by indigenous people with the intergenerational trauma is similar in India of the casteism going on for 3,000 years. So unless until we go to the root of those root causes, which are the reasons for the inequity, rest everything is a bandage, isn't it?
Yeah, so this is a tough question in global health. And I'll be honest with you, this is not only true for mental health. You're absolutely right. This dilemma, how much are health inequalities produced by structural forces? And to what extent can biomedical or health service interventions correct those is a real big dilemma. And I prefer in my own thinking is not to make this a choice, because that's a Faustian bargain. It should never be placed as, should we invest in correcting historical wrongs? Because to be honest, some of these cannot be corrected. They're now, the horse is bolted. You can't turn the clock back and suddenly change the relationship between indigenous people and settlers. It's not going to happen. How much can we really fix the problem now, both through social and political interventions, and how much do we also need to address the current problems that people face is a real practical concern. So I draw the analogy with, for example, the Ebola crisis. My colleague Paul Farmer, who's written a terrific book on this, says that the Ebola crisis in West Africa can only really be understood in those 3 countries. Why only those 3 countries and nowhere else? Is because of the toxic mix of the diamond trade, colonial histories, and ethnic war that was in itself the product of colonial rule. But that doesn't offer a solution for the person who actually has Ebola in front of you in the clinic. That's not going to help. So I prefer to think of this as a multipolar effort to try and address these problems. As physicians, the best thing that we can do is provide care for the person in our clinic. But as physicians, I think we have a moral obligation to at least acknowledge that there is a larger social context in which these problems are occurring. And when there are conversations about resources being allocated, that we should lend our voice of support for those resources that are being allocated to address those social factors. That's the best I can do. I certainly cannot fix the world, but I can at least fix the healthcare setting in which I work and recognize that the world is somewhat broken and I can lend my voice to it.
Thank you very much for a very eloquent and a very in-depth analysis of the global situation with mental health. I think you're doing incredible work, so thank you for that. The question I have is that if you look at the prevalence rates of mental illness, there's mixed evidence. It doesn't seem like it's increasing in any alarming rate, yet awareness and the numbers that are actually presenting in several healthcare systems is skyrocketing. And I'm wondering what your thoughts are about this dichotomy between evidence that says that there's no prevalence has not increased very much, yet we're seeing it enormously magnified right now.
So it depends on which demographic group you're talking about, because the only studies that are now changing that idea that it's not increasing is coming from systematic work that is documenting prevalence using the same measurement methods over time. The problem has always been that we've had a problem. First of all, diagnostic classifications keep changing every 10 years, which makes comparisons very hard. But measurement instruments also change. And we're lucky that in some countries like Australia, I don't know about Canada, maybe that's also happening here, but certainly Australia, in Britain, and the US, there have been longitudinal studies, cross-sections, repeated cross-sectional surveys looking at the prevalence of mental health problems over time. And what these are showing is that in young people, the prevalence is rising. In Britain, just last month, they released the latest data for 2018 on the prevalence of mental health problems, and they reported a twofold increase in the prevalence in young people, and this completely, over the last 15 years. And this completely matches the doubling of suicide rates that have just been reported last week in the US. A year from now, I can assure you that there will no longer be a question mark on whether it's increasing. There'll be now questions about what's the etiology. What is the reason for this increase and the need for an urgent addressing of this problem? You spoke about your university. Let me tell you, this is not just your university. The president of my university, Lawrence Bacow, last year, and in fact before him, Drew Faust, announced that the single most important issue for the undergraduate community in Harvard is mental health. Yep. And has set up a task force led by primarily people from the Faculty of Arts and Sciences, but also from psychology, to try and unpack what in heaven's name is going on with this incredibly privileged group of students, the most privileged, you could argue, by virtue of having made it into this university. They're cognitively the most capable students amongst their peer group, and yet they have such high rates of mental health problems. So what in heaven's name is going on here? We don't know the answers to that, but I don't think it's safe anymore to say that prevalence is not rising. So I think we need to understand better the mechanisms of that change, and we have to first recognize and acknowledge that, in fact, there is a crisis.
Thank you. So what are your thoughts about why? What is the etiology, you think?
I struggle with this. I don't know. The easy one, the easy sort of, but I could be a red herring, is social media. That keeps getting thrown at me. What do you think about social media? And I say, well, I just don't know. It's a 10-year-old phenomenon to begin with, and no one has even begun to research the impact of social media on the developing brain, on interpersonal relationships, on memory circuits, all kinds of things that could be potentially affecting your brain and your social world. But who the hell knows? I think these are all hypotheses. There are some nice preliminary studies that I'm sure many of you read, which are now showing the amount of time you spend on social media is associated with low mood and suicidal behavior. But what's the direction of causality here? So there's all these kind of questions. I do think it's a really very important research question. How does the social media world affect your brain and therefore your mental health? And I think that's going to be a very big area of inquiry going forward.
Thank you.
Hi, Dr. Patel. My name is June. I'm a second-year medical student from McMaster University in Hamilton, Ontario, just 5 hours away from here. But just first wanted to thank you for all the work that you've done over the years around the world, because no one else has stepped up to the plate. So I really thank you. And as a medical student who's looking into psychiatry as a future career, and I consider myself one of those, like you mentioned, 23, 25-year-olds with crazy ideas. So my question to you was, I was wondering if you had considered or been following some of the research around the impact of psychedelics on conditions like PTSD, treatment-resistant depression, and a whole other host of psychological and psychiatric illnesses, which have been for hundreds of years just so incredibly difficult to solve. And as a result, there's been a sense of hopelessness around many of these conditions. So I was wondering if you had been familiar with some of that work and what kind of implications that might have for mental health, global mental health.
So I think it's a very exciting area. The ability for us to re-engineer molecules so that perhaps some of the more hallucinogenic properties can be removed and those properties that actually create, the psychotropic effects without the hallucinogenic and the addictive potential is exciting. And ketamine is one example. The experiments that are being used in Yale right now with LSD being re-engineered. I'd say it's still very early days to examine how safe these will be in the real world. And so they could have global health application, and I certainly think it's a worthwhile inquiry, but I think it's still very blue sky science right now, particularly around safety, and also the long-term effects of these medications. Are they just effective for the 24 to 36 hours after you get the medication? Do they actually have any sustained benefits in reversing altered brain function? We are still, it's very early days to make any comments on that. But I will tell you one more thing. Don't assume that the only advances in therapeutics are going to come from biological interventions. That is to say, pharmacological interventions. Neuromodulation is another area where there's an incredible amount of exciting work happening. I'm really convinced now that actually here we may even have a scalable intervention, particularly the non-invasive neuromodulation therapies. And the other area are very specific mechanistically informed psychological therapies. And in fact, a lot of the work in global mental health has stripped away a lot of the jargon and the complexity around, for example, CBT, and taken very specific techniques like exposure or behavioral activation, and essentially mapped those specific techniques into syndromes of dysfunction rather than diagnoses. So you would say, this person has a very high severity of depressive symptoms, we will use behavioral activation, rather than saying, this person has a depressive disorder, and using the whole package of CBT. So I would not conflate therapeutic advances with only pharmacological interventions. There are probably more exciting stuff happening outside pharmacology.
Mm-hmm. And I wholeheartedly agree that we have to look just outside, beyond just the narrowed boundaries of pharmacological treatments. But one interesting thing from the hallucinogenic literature is that for one smoking cessation study, I believe it was at Johns Hopkins, the most effective treatment from those studies using psilocybin mushrooms only happened when the participants had experienced a profound transcendental moment. I think that was the term they used.
Right.
So there is maybe that may be an indication that some of the hallucinogenic properties
itself is therapeutic.
Itself was therapeutic, or some of the things that we may have had a stigma around may have actually had a great role. So in terms of, I think the question I'm trying to get it out is, I think there needs to be a re-understanding or a greater understanding of the mind and consciousness and its role in mental health treatment. I was wondering if you had any.
Thank you.
Thank you for your talk, Dr. Patel. I found that very inspiring. My name is Olivier. I'm a student here at Ottawa. And my question is, what advice would you have for new medical trainees to keep in mind the context of global health, global mental health throughout their medical education?
So first of all, I'll make a more general piece on global health, because I think, as a young medical trainee, you're not specifically, aligned to one or another discipline of medicine. So the most important lesson I have is the same one I give my students in Harvard, which is you don't have to travel to find social injustice. You can look around you. It's never too far, but you're probably missing it as you drive past. So I think the most exciting idea about global health is global. And some people treat global health as just it's like a euphemism for tropical medicine. It's not a euphemism for tropical medicine. Tropical medicine was a colonial discipline that was championed by the medical schools of Western Europe mainly to help understand the kinds of diseases that their soldiers and administrators were being afflicted by in the tropical colonies. That history is one we have to consign to history. It was powerful and important, but global health is about people everywhere. And the heart of global health is disparities. And I'm sure in Canada there are many disparities. And so I say this because otherwise students think that it means you've got to travel somewhere and you've got to take 3 months off from your clinical studies. No, you don't. You can start doing global health work while you're a medical student by focusing on populations that are historically disadvantaged, and then extend these lessons when you finish to actually doing a global health career that could be more international.
Thank you.
Thank you very
Your
much.
question will be very brief, sir.
Yeah,
Thank you.
Gunther, I just finished reading The Inner Level, which is an extension of the Spirit Level from Wilkinson and Pickett, looking at inequality and ill health, and particularly mental ill health. And would you look at, argue about the increase in neoliberalism, or whatever we call it, and the inequality that's increasing throughout the world and mental health?
So I love the book Spirit Level. It's one of the books that I consider one of my North Stars in trying to understand the impact of societal determinants on well-being. I didn't know there was a book called Inner Level, so I'm going to look that up now, so thank you for bringing it up. Yes, in fact, I've done research in this area. We've published a lot on the area of societal inequality and poor mental health, and there's in my view, there's a very compelling evidence base, but the problem with observational evidence is that you can then read it whichever way you want, depending on your political dispensation. So I do believe that rising inequality in society is affecting social order and harmony. I don't think we have to look very far to see signs of that in very many different ways. I believe that one of the factors that is fueling mental ill health in young people is that it's dashing their hopes for a better future. They are, and I speak very privately from my own son, I can see that his own sense of safety, security, and certainty about what lies ahead as he grows into adulthood is completely different to mine, or mine was. I think there is a huge amount of uncertainty, for example, about environmental sustainability in young people. I was reading just in today's paper, there have been 10 suicides in the last 2 weeks in Hong Kong. It was in The Guardian today, so you can look it up. There was a story with lots of people in Hong Kong saying that this is a spike of suicides in 19 to 20-year-olds that has never been seen of in Hong Kong. And the only way they can explain it is a sense of hopelessness in a society that is currently heading, no one knows exactly where, but it doesn't look very good. So I do think at a larger level, young people are growing up in a system where there is growing uncertainty about climate, about social harmony, about polarization, and this seems very abstract for biomedical researchers to get their head around, and it is actually very abstract, but I do think, for me, the evidence seems certainly very plausible.
Dr. Patel,
Thank
on
you.
behalf of the University of Ottawa and colleagues from the audience, I would like to thank you for your presentation. As a small token of our appreciation, I would like to present you with this gift. Please
Small?
join me in thanking our presenters.
Thank you so much. Thank you, Dr. Chambonneau. Thank you so much. Wow, that's not so small, but thank you.